Good evening, everybody. This is Dr. Rick Lehman. Today's date's 10/26/2020 in your corner with CORA. And tonight we're talking about distal radius fractures, which is probably one of the most common orthopedic injuries. And we're actually talking about it in the guise of football, playing football and injuring your distal radius, which is not uncommon for sports practice, hand guys, etc. We've got a great crew tonight, so I'm going to have everybody introduce themselves. Caitlin, why don't you go first?
My name is Caitlin Whiteley. I'm a physical therapist and I work for CORA at our South County office here in St. Louis.
Dr. Glisson, go ahead and introduce yourself and tell us a little bit about yourself.
I'm Dr. Colleen Glisson. I'm a hand and upper extremity orthopedic surgeon. I'm with Advanced Bone and Joint in St. Charles.
That's awesome. Hey, listen, thank everybody for hanging in there with us tonight. So we're going to talk about distal radius fractures. And prototypically, I think orthopedic surgeons see distal radius fractures. We saw them as residents, we see them in practice. And generally, you fall on an outstretched hand and you injure your wrist, you break your wrist, and generally go to the emergency room. So we're going to kind of take it from the top. And Dr. Glisson, why don't you initially describe the anatomy of the distal radius and what are we really talking about here?
So the distal radius is the end of the radius bone that's at your wrist. Most people will call it a wrist fracture, although the true wrist is a lot of little bones in there as well. But distal radius fractures are probably more common than other wrist fractures. So.
Sounds good. So, and describe who gets distal radius fractures. Tell us about the age ranges and kind of who is most commonly going to be injured to fracture their distal radius.
Well, first of all, we see a lot of pediatrics with distal radius fracture, kids with open growth plates, and some of that is our sports and football population. In general, we see younger people with distal radius fractures, usually from a little higher energy stuff, sports, accidents, things like that. And then we tend to see it in the older population, usually from falls from a standing height.
And why do old people break their wrists? I mean, why don't people in the middle break their wrists?
It's probably more their bone density. As we get older, our bones get a little weaker. We might have a little bit of osteopenia or osteoporosis, and we're more susceptible to breaking that bone at our distal radius.
Great. And then why do young people break their wrists? What's their predisposition?
They're more active. They're doing crazy things. They're playing collision sports. They fall off of bikes and swings and all those types of things.
Yes, they do. In the older population, did you get DEXA scans? Do you talk about osteoporosis? Do you treat osteoporosis or generally just treat the fracture? Or do you ask them about other bones that they may have fractured? How do you handle that in your practice?
I generally ask them, but I feel like I'm not the one that usually manages the medications for bone density. But if I'm concerned about it, I definitely tell them to talk to their primary care doctor, because oftentimes once you have that broken distal radius, it puts you into a category where you may need treatment for your osteoporosis.
Great, and that's true. And I think those people, I mean, it's much more common now to see people getting treatment for their fractures than old school. Back in the day, we didn't do anything. We just treated the fracture, then they get spinal fracture, get a hip fracture. We didn't have all these medications though to treat them, so we just sort of accepted it.
Yeah.
In terms of intra-articular versus extra-articular fractures, kind of tell everybody listening what the difference is and why it's important.
So an intra-articular fracture means that it actually goes into the wrist joint. So you broke the part of your distal radius that articulates with those other wrist bones. An extra-articular fracture means that it's farther down in the bone. So we worry a little bit more about the ones that actually go into the joint, because if those aren't lined up as well, you're more likely to get arthritis.
So the ones that go into the joint make you more nervous than the extra-articular fractures in terms of progressive arthritis or arthritis down the line.
Correct.
Very good. And what other injuries do you see? So somebody comes in with a distal radius fracture. Are there any associated injuries that you look for? Other injuries of the wrist, other injuries, radial styloid, ulnar styloid? Tell us what associated injuries you might see with a distal radius fracture.
So the most common is fracturing the distal ulna too. So the big bone at your wrist is the distal radius and the little one is the distal ulna. And the most common associated fracture we'll see is that little tip of the distal ulna. Then there's a few other special circumstances. If the fracture's at the radial styloid, they're more likely to have a scaphoid fracture or a scapholunate ligament injury. And then there's a whole other category of what we call a Galeazzi fracture, where when you break your distal radius, it dislocates the joint, the distal radial ulnar joint between the two bones.
So if you get a Galeazzi fracture, you have to treat the fracture and the distal radial ulnar joint, or kind of what do you do?
Usually I treat the fracture, and most of the time the distal radial ulnar joint takes care of itself. There's actually a few studies about where the fracture is. If once you fix it, it's more likely to be stable or not, depending on, I fix the radius fracture and then usually examine the joint and see how it feels, if it's stable, if I can just put them in a splint for a few weeks, or if I need to put a couple pins across it.
That's awesome. And so somebody comes in, they have a distal radius fracture, they went to the emergency room, maybe they have a little deformity. Generally, what x-rays do you suggest? And do you ever get a CAT scan, a better look at the fracture? Kind of tell us your management as that patient presents.
So the standard wrist x-rays, it's usually 3 or 4 views, an AP, a lateral, an oblique, and then sometimes they'll get the scaphoid view too. I usually go off, unless there's a really bad view, I usually go off of whatever they bring me from the ER urgent care. Sometimes you send people for another x-ray if needed. Things I look for, there's a couple criteria. One is called radial length. Like your radius should be a certain length above your ulna. It should also tilt up, or it's called radial inclination, where it's at a bit of a 20-degree angle. You want to look at that. And then the other one is on the lateral view. You want to look that it's tipped forward a little bit rather than backward is what it's supposed to be. So those are my main parameters and then the other one is the joint surface. Those are my main parameters that I look at. I wouldn't say there's a hard and fast number on any of them, because there are some that are borderline, but I feel if it's considerably shortened, if the articular surface is stepped off by more than a few millimeters, and probably the biggest one is if it's tipped backwards, we're probably going to be talking about surgery.
So if they come in and they have a dorsal inclination, you're more likely to recommend surgery than if their alignment's pretty good.
Yes.
And in terms of pulling out the length, what do you think is an acceptable amount of shortening?
If they're about ulnar neutral, in general, I think that's fine. And the other part about this is you really have to talk to the patient about what their expectations are. There have been a lot of older patients that really don't want surgery, and we leave it be. And you know what? They do just fine. But the expectations of an 80-year-old woman versus a 20-year-old male are going to be quite different. So I think that's half of it, is talking to them about what you expect.
Right, and I think that's right. I think you have to manage your expectations, and I agree with you. Older people generally don't want surgery, and as you said, they do just fine. So go through the treatment, kind of the whole gestalt in terms of your treatment. So give us your treatment protocol in terms of who you're going to treat in the cast and how you decide versus who needs to get fixed, and what the different options are in terms of the fracture pattern, displacement, shortening, etc.
Okay. So in general, we'll just throw this out there. Kids, we're thinking like the little kids with open growth plates that come in with an angulated distal radius fracture, even somewhat displaced, they almost always get treated in a cast. Now, every once in a while, one is really angulated and you have to do what's called a closed reduction, where you take them to the operating room or even do sedation in the ER and straighten it out a bit. So we're not going to talk anymore about the kids because they're almost like a different, I don't know, beast. An adult who comes in with a wrist fracture that's acceptably aligned, usually I'm going to say, no, I don't think you need anything done for this. Let's treat this non-operatively. And I tend to cast. I think it protects them better. It keeps them from doing stuff. I worry less about it displacing. I tend to put them in a cast for usually about 4 weeks and then get them out and get them moving and switch them to a splint. Somebody with a little bit of a borderline fracture, the alignment's not perfect, but maybe it's a little more dorsally angulated than I would like. I'm going to talk to them about more options. Either treating it in a cast. Sometimes I worry that it's going to change over time, and I'll even put them in a cast and have them follow up in a week and re-x-ray it and see what it's doing. And sometimes I think people just need a little bit of time to think about it too, and what their options are. So option one is treating it non-operatively, seeing how it does. I actually think the most important factor with distal radius fractures is how well your fingers move. So if you've got good fingers and it's not too displaced, you're probably going to be just fine. Options for surgery are doing, depending on the fracture, if it's extra articular and it's a younger person, there have been a few occasions where I've done a closed reduction and pinned it. I would say those times are becoming fewer and further between, because I feel like if I'm taking him to the operating room, I want to put him in something that's going to get him moving faster. So with the closed reduction and pinning option, I still usually put him in a cast for a few weeks. And those pins usually come out between 3 and 4 weeks. The other option, which I would say is the standard of care for displaced distal radius fractures, is open reduction and internal fixation. Depending on the fracture pattern, most often I use a volar plate. There's a few other ones where, for whatever reason, I'd go dorsal or something like that. But the vast majority can be handled with the various volar plates. I usually put them in a splint for about 10 days afterwards that they can't take off, and then they get switched to a removable splint and can get going with range of motion.
That's awesome. So Caitlin, kind of give us the post-op PT in terms of when you want to see them, how does PT go, how long does PT last, and what they can expect in terms of progression.
Yeah, I mean, I think in terms of when does PT start, as we've kind of already alluded to, no distal radius fracture is the same. So depending on what exactly was fractured, what other things were injured, that kind of affects when I may start with them. I tend to lean to the doctor and what their preference is, but I always like to get them in as soon as possible. I think the sooner we get them moving, the better their results are going to be, assuming that they're healed when I see them. So some of that is like age dependent. I'm obviously going to see my younger athletes a little bit sooner than I see my older adults, just because they have faster bone healing, and I don't want to get them moving until their bone's totally healed. In terms of my approach with therapy, I focus on range of motion first and foremost. And I think sometimes we can get this tunnel vision and look just at the distal radius, but I kind of like to look at the wrist, the fingers, the elbow, and even the shoulder. Depending on what splint they were in and how big the splint is, they can have range of motion deficits all up and down the chain. So I want to treat all of those deficits. And then really thinking, especially with the youth athletes, what sport are they trying to return to and what position do they play within that sport? I'm treating a lineman right now with a distal radius fracture, and his biggest thing is I need to make sure he's able to weight bear through that arm so that he can push and pull players. Whereas a receiver, I'm a little bit more focused on dexterity and returning him to full strength so that he can grip and catch that ball. But first, like with everyone, range of motion first, dexterity following that, and then strength along the way as appropriate and as needed for the patient.
And when you see that distal radius fracture, and maybe they start to complain of a little bit of shoulder pain or a little bit of stiffness in the shoulder, kind of what's the next, how do you approach that?
So I try to ask them when they're having that shoulder pain. I think a lot of times if I can identify the activity that they're having that shoulder pain, I can identify potentially what motion, like what wrist motion they may be limited in. So I had this older lady, she was always complaining of shoulder pain when she would like open her door, and it was because her pronation and supination just wasn't there yet. So really trying to address the more immediate problem of that pronation and supination, but also treating her shoulder as well and doing some rotator cuff strengthening to allow her to be able to have that increased strength and range of motion that she may not have yet from her wrists, because we're still working on gaining that.
Dr. Glisson, so give me the complications. Lady comes in, she has a distal radius fracture. You don't get too excited. You put her in a cast. Her fingers start to swell, starts to lose a little bit of motion in her shoulder. What do we need to do here? Well, what's going on and what do we need to do here?
Well, stiffness is a problem. And that's why I actually think, like I said before, the single most important thing is getting those fingers moving. Even if I still have them in a cast and their fingers are stiff, I get them to therapy. They need to move their fingers. Same thing, frozen shoulder is not uncommon either, because patients are guarding it. They're not moving their arm around as much. Getting into therapy to adjust those. The other thing I worry about is, could they be developing a complex regional pain syndrome? We don't see it that much, but when it happens, it's not good. But they tend to have swelling and hypersensitivity. And again, my first line of attack is therapy. Get it moving, do the desensitization, go from there.
And what could someone expect? So you have a younger person, they're, like you said, 20 years old, they have a distal radius fracture, maybe they end up with a volar plate, they have an excellent reduction. What can they expect in terms of results? So when the athlete says, when can I go back to playing basketball, or says, when is my wrist going to feel normal? What do you tell them?
The young person will probably be back to stuff fairly quickly. I would say some activities they're going to be doing by 6 to 8 weeks. I tell them before you can even think about doing a push-up, it's probably going to be 3 months. And I tell all my patients, especially the older ones, it's 6 months before you forget that you broke it. Not that you're laid up that long, but before you're not thinking about it when you're doing things.
You think about 6 months.
Yes.
And when would you, if you had someone who had a plate, had a good reduction, had an uneventful course, would you let them play football or basketball at 6 to 8 weeks?
Most likely, with some protection. And
you want to explain complex regional pain syndrome?
Complex regional pain syndrome is when your nerves get basically crazy from, usually it's after an injury. Sometimes it can just happen remote to the trauma. But it's characterized by swelling, hypersensitivity, and stiffness. But it's basically a nerve problem. Therapy, usually start them on gabapentin. Hopefully, rarely I end up sending them for they can do some nerve blocks, these stellate ganglion blocks. Fortunately, I haven't had any patients that have needed those in a while, but it's tough.
Wrist fractures. I mean, that's you'll see people with non-displaced wrist fractures, and next thing you know, their shoulders are stiff, and they're like, I got this burning in my hand, and you're like, oh my gosh. So
I know. I've tried to jump on it quicker, and there's all those studies that say like maybe vitamin C helps, prevent it. it's hard to get people to take anything regularly.
Right. No, I agree. I think in a controlled situation, we've tried that and we haven't had a whole lot of luck. All right. So let's wrap it up. You guys have been great. Thank you very much. This is Dr. Rick Lehman, for In Your Corner with CORA. Again, 10/26/2020, a little spike in the pandemic coming. So, be safe, stay at home, social distance, wear your mask, be healthy. Thank you.